Are we gonna get a countdown?
So the recording has started. Y'all can begin now, or you can begin when you felt enough people have had time to come into the room.
Good afternoon. Thank you for joining the HIV Aging and Co Morbidities breakout session, The Grain of the Pandemic, that will be brought to you today by Dr. Veronica Ayala-Sims. After graduating from the University of Virginia, Veronica Ayala-Sims went to work in HIV public policy at the Association of State and Territorial Health Officers in Washington, D.C. This was in the early 1990s, where the national policy discussion about HIV was just beginning. During her time doing public policy work, she was inspired by the physicians, those actually providing medical care to those living with HIV, who were also working as advocates in the HIV policy arena, and decided to pursue a career in medicine. She attended the Medical College of Virginia, School of Medicine at Virginia Commonwealth University, and after graduating, remained there and completed a combined residency in internal medicine and pediatrics. Still inspired by her days working in HIV policy in Washington, D.C., she decided to apply for the fellowship in HIV medicine at the Virginia Commonwealth University Health Systems. After completion of her fellowship, she remained at VCU, where she joined the faculty in 2010 and became the principal investigator and clinical director of VCU's Ryan White-funded HIV programs. In this role, she not only participated in the training of future physicians who will be providing care to persons living with HIV, but also provided medical care to over 300 persons living with HIV in the Central Virginia region. In 2018, she left VCU and joined Capital Area Health Network. In January of 2022, she joined the staff of the Daily Planet Health Services, where she has been able to expound on her passion for serving historically underserved communities, not only serving the HIV positive community, but also other communities such as the Spanish-speaking community and those who are either uninsured or underinsured, homeless, or a recent immigrant to the United States that often face challenges here accessing medical care. At this time, let me introduce to you Dr. Veronica Ayala-Sims.
Hello, everybody. So I'm not used to presenting on Zoom, so I'm hoping that all of the things go well, including that my dog does not start barking crazily and that my doorbell doesn't start ringing. So thanks, Mike, for the introduction. So one of the things that when I was asked to do this presentation on HIV and aging, I realized that that's not a topic that I had kind of delved into quite as much as some of the other topics that I have delved into over the years with respect to HIV. So things that I'd like to accomplish today is to look at the current epidemiology of HIV disease in persons 55 years and older. And for the purposes of speaking of older persons, I hope I'm not hurting anyone's feelings by saying that it's 55 and older. But that's the kind of cutoff that is used by the folks who are collecting data. So even though 55, especially as I get older, is not older, as far as I'm concerned, that is the cutoff based on the way that data is collected. Talk about the geriatric assessment, which sounds kind of boring, but it's actually a lot of what we already do in our Ryan White clinics with our multidisciplinary approach to patient care. Talk about clinical assessment considerations for older persons living with HIV or AIDS, which the literature abbreviates as OPLWHA, which is very long. And then talk about some of the challenges and opportunities for improving the care of persons, older persons living with HIV. So just one thought that came to mind as I was preparing this, and as I've been navigating some of the challenges with my own parents as they are aging, is that aging is a spectrum and everyone progresses through the spectrum differently. So one of the things that we can't lose sight of as we think about these things is that each person comes to the table with their own story, their own history, and our mission in trying to provide comprehensive healthcare to them is to try to glean as many details, but also try to construct a care plan that addresses the fact that those folks are individuals. So just looking at the numbers, because it's not a presentation if you don't talk about epi. So we'll look at globally, nationally, and locally. So I was looking at the original MMWR came out June 5th, 1981. So it's been 41 years since the original article detailing what was to be the HIV pandemic, or the beginnings of the HIV pandemic, was published. So it's a somber day if we think about it in terms of historically. We've already lived through, who would have thunk that we would have lived through another pandemic in our lifetimes with COVID. But just that, this just gives us some perspective of how long we've been living with HIV. So this is data from the United Nations AIDS program. So somber anniversary in the sense that we haven't been able to eradicate HIV. However, the good news is that we have gotten really, really good at treating HIV to the point that for most people, it is now a chronic medical condition. And so the numbers of people who are aging with HIV have increased exponentially as we have gotten a lot better at taking care of people who are living with HIV. So these are the numbers of people living with HIV over the age of 55 in 2020. So if you look globally, the US didn't report any data to the UN AIDS program, but you can see that the heavy burden in sub-Saharan Africa, Latin America, and South America. So the next set of slides, I wanted to kind of get an idea of how is the US doing in terms of caring for people living with HIV? How are we doing in terms of diagnosing, getting people into care? retaining people in care and addressing some of the additional social determinants of health that may impact their ability to remain engaged in care. So this is data from the CDC. In 2019, there were about 1.1 million people who had HIV in the United States. And if you look at all age groups, about 87 per every 100 knew their status. But we as a country did really well in those over the age of 55. So really good at making sure that those folks knew their status. And a lot of that probably has to do with the fact that as people age, they tend to have more contact with healthcare systems, and requirements for or recommendations and guidelines for HIV testing are being followed. If you look at new diagnoses in the US and dependent areas, which means the territories, you can see in men and women that we're still diagnosing quite a few people 55 and older. So these are new diagnoses. So these are people who are coming to their HIV journey, so to speak, at an older age, with all of the things that entails. And if you look here, the percentage is much higher in women than in men. If you look at people diagnosed with HIV in the 44 states in the District of Columbia by age, you can see that for every 100 people diagnosed with HIV that was 55 and older, 75% were engaged in care. So that's kind of consistent across the board. We're still not meeting the kind of 90-90-90 goals set by that have been set for engagement, retention, and care. But there's not a whole lot of difference in terms of receiving care, retention and care, and viral suppression across the age groups. If you look at deaths among persons living with HIV, not surprisingly, a majority of those deaths have occurred in persons 55 and older. And we'll talk a little bit more about some of the comorbidities that come into play that have an impact on morbidity and mortality in those persons 55 and older. If you look at depression and anxiety, we see that, again, kind of consistent across the board, that there's a significant amount of depression and anxiety reported amongst people living with HIV across all age groups. And this is pre-pandemic. So I'm pretty sure that if these data were to be collected now, that those numbers would more than likely be higher. And each age group has experienced the pandemic somewhat differently. So it would be interesting to see what that data looked like now. In terms of other social determinants of health, stability of housing, the rates of homelessness in persons 55 and older were much lower than in those who are younger. But here at the Daily Planet, we take care of a lot of patients who are older, who are unstably housed. So, 6% is low when you're looking at just percentages, but behind each percentage is an actual person or group of people who are experiencing homelessness and all of the challenges that entails, especially as you get older and you may have more comorbidities and a lot of other associated issues and concerns. Persons who are 55 and older tended to be better at attending medical appointments within the last 12 months than people who are younger. I think a lot of it has to do with, I think by the time that people get into their 50s and older, they tend to be more engaged on a consistent basis with healthcare systems. But again, that is not always true, as we see at the Daily Planet all the time. Nearly half of the folks who responded to, or for whom the data was collected, had some sort of ancillary need in the last 12 months, whether that be case management or whether that be dental, you can see the yellow is dental, which has been a challenge. Access to food is another issue. And then mental health services. You can see that, interestingly, mental health services were not reported in some of the younger age groups, but were reported in persons who were 55 and older. And then we get to the new infections. So we can see that even though the infection rate is lower amongst people who were 55 and older, we're still seeing new infections in that age group. We can speculate as to the reasons why, people who may be re-entering the dating scene after not having been sexually active or with more than one partner for some time, substance abuse, mental health issues. We can speculate as to why we're still seeing new infections in persons who are 55 and older. PrEP, that is something that we should be having discussions with when we talk to our patients who are 55 and older. And I think there has to be a certain comfort level with medical providers, case managers, and discussing some of the things with people who are older who may look like our parents, and asking them questions that may seem kind of personal and embarrassing about sexual practices, substance use, and things like that. So PrEP should be offered to persons who would qualify based on sexual behaviors or drug use behaviors. If you look at the people who reported taking their medicines consistently, those 55 and older tended to do a better job of taking their medicines more consistently, but that's still not, that's 67%. So that's a little over half, but that's still not great. And then we talked about that. So this is Virginia data. So this is from as of December 2021. These are the number of people living with HIV, not new diagnoses, but all comers who had HIV newly diagnosed or have been living with it for some time. And you can see, if you look at this trend, we're also seeing kind of an increase in the number of people who are older, over 55, who are living with HIV in the Commonwealth. Not so many new diagnoses, 55 and older in Virginia. So again, going back to the previous slide, these are people who have probably been living with HIV for some time. Okay, so we'll talk about some things that we should be thinking about as we're caring for persons who are aging with HIV or persons who are living with HIV, older persons living with HIV. So some of the challenges exist with current guidelines. So the guidelines that do exist for the care of people living with HIV in general don't always do a very good job of addressing kind of the multifactorial nature of conditions. So how do, the role of diabetes and heart disease and homelessness with age, for example. Measurement issues, like how do we capture and measure those folks? How are we defining which groups? Do we need to split out do we need to split it out by decade, 55 to 65? Because 55 to 65, some of those folks may still be working. And then, do we need to stratify it in a different way? Lack of representation in clinical trials. A lot of the clinical trials have age cutoffs that do not include people who are over a certain age. Screening and guideline inclusion, which kind of goes back to the fact that older people a lot of times are not included in general trials that address kind of a general population, such as those living with HIV. And then limited guidelines addressing geriatric symptoms, particularly for people living with HIV. So one of the things that I want to talk about was the comprehensive geriatric assessment, which is basically a multidisciplinary kind of holistic way of looking at a patient that walks into your clinic, to figure out what are their medical, psychosocial needs and what deficits may they have in terms of being able to manage their healthcare on their own, manage their medications, get to appointments, things like that. The goal is to develop a coordinated plan for intervention to basically maximize the overall health of the patient. There's data on using comprehensive geriatric assessments kind of in inpatient settings or in nursing home settings. There is some data, mostly from Europe, that looks at its utility in primary care. There's not particularly strong data that suggests that there's some utility in primary care, but there are, one review did suggest that there are some benefits, including cost effectiveness, improved medication adherence, reduced hospitalization admission rates. There's not really consistent data saying that it affects death outcomes in patients living with HIV. And then there's no peer-reviewed literature to address how the comprehensive geriatric assessment works in populations of people who are aging with HIV. Okay, sorry. So there's a bunch of different domains, and we do a lot of this already in Ryan White Care programs because that's kind of what we do. We do have the benefit of having funding to provide some wraparound services and some extra staff people with different expertise that can help to form these comprehensive plans and do these assessments for patients. So physical assessment. So that would be the medical provider checking vital signs, doing a physical exam, looking at things such as weight and nutrition. Do their medications make sense? Socioeconomic and environmental issues. So housing status. Is their home safe? Can they get in and out of their house safely? What are their support systems? Do they have family that lives with them? Do they have, who is their next of kin? And populations of folks who are living with HIV, there's, stigma still exists. So do their next of kin know about their HIV diagnosis? And how do we broach those conversations with folks as they age so that, if they wind up having to have other people involved in their healthcare, that they feel that they're able to share the entirety of their health information with those folks. Insurance coverage, that's a biggie. So as people age, their utilization of healthcare services increases. So do they have insurance coverage that would help pay for things like home health nursing if it became necessary, or for blister packing medications to improve adherence, or for transportation to their medical appointments? Mobility and balance. So those are also things that we assess, because that has a lot to do with can they walk into the clinic? How are they going to get there? One of the things that is one of the tests that is used and has been used in patients living with older patients living with HIV is the time to get up and go, which is called the TUG test. So you look at a patient, you watch them get up from a chair, walk 3 feet, turn around and sit back down. And if they take over 12 seconds to be able to do that, then you worry about whether or not they have some mobility issues. And actually, there's just looking at frailty, which is another measure that we look at. So there is a phenotype, a measure that has been used in HIV research that looks at several different domains. So weight loss. Have they had a weight loss of 10 pounds or greater than 5% of their body weight in the past year? Exhaustion. Do they feel tired all the time? Low physical activity levels. Do they need some assistive devices to get into clinic, a walker, a wheelchair? Slowness. So is their TUG score greater than 19? And Also weakness. So is their strength abnormal? Because all of those predict how frail the patient may be, and also predicts some of the, is a predictor of outcomes. So people who are frail may have more falls, or they may not be able to get into the clinic, or they may wind up with increased hospitalizations due to their frailty. Cognition and safety concerns. So there's several different scales that are used to kind of measure cognitive abilities. The ones that have been used specifically for HIV are the HIV dementia scale or the International HIV Dementia Scale, which specifically address for HIV-associated neurocognitive disorder. The mini mental status may not be as effective in persons aging with HIV as it can be kind of confounded if you have neurocognitive disorders from your HIV. And the MoCA is one that has been used commonly in several of the clinics where I've worked to do some assessment. Neuropsychiatric testing is great if you can have access to it, but it's not always easily accessible. Psychological and mental health. So depression and PTSD are very common among people living with HIV. So the PHQ-2 and PHQ-9 are commonly used outpatient tools, and polypharmacy is a big one. So there is there's potential for a lot more drug-drug interactions in older persons living with HIV than in older persons who are HIV negative. And each additional non-antiretroviral medication has conferred in one study an excess risk of hospitalization. So each time you add a non-antiretroviral medication to a patient's list of medicines, the potential for there being a drug-drug interaction that lands that patient in the hospital increases. This is one of the tools that, one of my favorite tools for patients, both older and younger, to help manage medications. It's a great tool. Getting access to it can be challenging sometimes if the patient does not have an insurance policy that will cover it, or if there is no payer. Some clinics have people in the clinic that will actually will pack a pill box for a patient if they don't have access to having a pharmacy do it. But it is a very good way of addressing things like literacy. I have one patient right now who does not read or write. So he is unable to kind of figure out what medicines he's taking and when he's supposed to take them. So we give him pill boxes, and he just knows that he just has to take them out of the little pocket each day. One of the things as we're assessing older persons or any patient living with HIV, but particularly older persons, we want to know what their antiretroviral history is. There's some drugs that we no longer use anymore, such as the D drugs, so stavudine, DDI, D4T, and D4T, that were some of the first drugs in our arsenal. We don't use them anymore because they have horrible side effects and we have better drugs now, but they were known to cause peripheral neuropathy. And over the years, I have taken care of patients who have residual neuropathy or nerve damage due to having been on those D drugs in the past. History of adverse effects. Did they ever have an adverse reaction to a medication? So we wouldn't want to use that medication again. Drug interactions. There's multiple different drug interaction checkers that we can use to make sure that we're not adding medicines that are going to potentially cause any interactions that could wind our patients in the hospital. Let's see. Assessment of what medications the patient is taking should be done at each visit, because sometimes our patients will go to more than one place, or they will have gone to the ER or to an urgent care and somebody gave them a new medicine. And so if we don't know what they're taking, we can't assess the potential risk for drug interactions. Nutrition, weight loss, weight gain. Again, significant weight loss is a sign of frailty, which again is which increases the risk for illness, complications, hospitalizations, falls, etc. Weight gain that is unintentional can also predispose people to other issues such as diabetes or problems with cholesterol levels and things like that. Advanced care planning, that's not something that we talk about a lot as a society, but it's a conversation that we should have at some point with some of our patients who are living with HIV, particularly as they age. Who's the decision maker if they become incapacitated? We had a patient recently who had no family and was hospitalized for a month, and there was nobody to kind of speak for the patient. Do the decision makers that they have appointed, are they aware of the patient's HIV diagnosis? I have told patients in the past, you think about if and how you want to disclose your HIV status to those who you would want to be your decision makers, because you don't want them finding that out at the moment that you might be in the hospital and can't speak for yourself. So maybe facilitating those discussions with some of our patients. There's a good tool called Honoring Choices, which enables patients and their caretakers to start having those conversations about advanced care planning. What happens if they're incapacitated? What happens, what kind of care would they want if they are unable to do certain things? So multimorbidity. Multimorbidity is basically the accumulation of multiple serious medical conditions. It impacts hospitalization in older persons. So the more medical problems you have, the more likely you are to, the likelihood of you winding up in the hospital increases. The prevalence of comorbidities may be higher in persons living with HIV due to multiple factors. And I'll talk about a couple of those in a second. But one of those is continued activation and inflammation caused by the HIV infection itself, side effects from medications, lifestyle factors such as smoking, substance use disorders, and things like that. The onset of comorbidities in persons living with HIV often starts earlier than in their HIV negative counterparts. One of the reasons for that is that our immune system ages and as we get older, but the presence of HIV itself accelerates the aging process of our immune system. So we might not be chronologically older, but our immune system might be older in the setting of HIV than in someone who is not HIV positive. So as we get older, our immune system becomes less adept at responding to infections, which is why we see that people, as they get older, can become more susceptible to certain illnesses than people who are younger. That's called immunosenescence. So our immune system ages. And then inflammaging is the idea that in the setting of the chronic inflammation that occurs in the setting of HIV, that also advances the age of our immune system. This is data from an urban Ryan White clinic looking at some of the comorbidities that we see commonly in patients living with HIV. And you can see that those the rates of the percentage of patients living with those conditions increases, not surprisingly, as people get older. So common comorbidities in people aging with HIV. So cardiovascular disease, bone abnormalities, kidney disease, liver disease, neurocognitive and psychiatric disorders, malignancies, and as we talked about a little bit earlier, frailty. So diabetes. It's estimated that up to 15% of persons living with HIV may have diabetes. The increased prevalence of diabetes in people living with HIV is probably, it's multifactorial because none of these things are kind of exist in a silo. So aging population, so diabetes tends to be more common among people as they age. Lifestyle choices, including diet, although it is very expensive, especially nowadays, to eat quote unquote healthy. So we have patients that live in some of our congregate and Daily Planet's congregate living facilities, including the Healing Place. And I've had several of those patients complain that all they get is carbs because carbs are cheap. So it's hard to have access or to be able to control your diet if you're on a fixed income, or if you're homeless, or if you're dependent on others to prepare your meals and do the shopping for you. And people living with HIV, the hemoglobin A1C may underestimate the actual level of their blood sugar. So the recommendation is that before starting antiretroviral therapy, you should check a fasting blood sugar and an A1C, and then recheck that 3 months after starting. In people who had diabetes prior to starting antiretroviral therapy, the A1C can be considered to be more reliable. There's a little bit of a difference in terms of recommended goals for A1Cs in people living with HIV. The American Diabetes Association says less than 7, which is what most of us follow. The American College of Physicians says 7 to 8. It's a little bit more permissive. In terms of management, the management of diabetes in persons living with HIV does not change based on their HIV status. One of the things to keep in mind, though, is the potential for drug-drug interactions with some of the diabetes medications and antiretrovirals. This is a very tiny slide, but this is talking about cardiovascular disease. So persons living with HIV have increased risk of cardiovascular disease, including MI, stroke, heart failure, and sudden cardiac death. And again, part of that is the ongoing inflammation, including of cardiac vascular blood vessels that occurs in the setting of HIV, even once folks have been started on antiretroviral therapy. So there's HIV specific factors, including viral load. The higher your viral load, the more inflammation you have going on, the chronic inflammation and immune activation, as well as non-HIV kind of traditional risk factors such as diabetes, hypertension, and smoking, which we know those rates can be increased in our patients who are living with HIV. So when we encounter patients, we should check their blood pressure, weight, check their blood glucose, assess other risk factors. Some of the antiretroviral medications can increase cholesterol, can have an impact on cholesterol levels. So we should be checking lipids prior to starting therapy and 3 months after that. Smoking cessation. Smoking is bad. We all know that, but it bears repeating because we have a lot of patients that smoke, and in conjunction with their HIV causing chronic inflammation and immune activation, smoking does the same thing. So that increases the risk of cardiovascular disease. The traditional risk calculators, Framingham and the American Heart Association risk calculators, are helpful, but there is no HIV specific cardiovascular risk factor. So some folks have actually suggested that when you calculate that risk score of having some sort of cardiovascular event in the next 10 years, that you add 1.5 to 2 to that score to account for HIV. There'd been talk of coming up with some calculator that took HIV into account, but that hasn't come to fruition yet. As well as aggressive treatment of HIV to make sure that you're bringing down that viral load, and because that helps. The higher the viral load, the more inflammation is there, the higher the risk of cardiovascular events. Bone disease. So there's again higher rates, higher prevalence of lower bone mineral density in persons living with HIV than in HIV negative persons. There are, again, HIV related factors, including how some of the products of HIV replication can impact bone turnover. So the bone turns over much faster, creating weaker bones. Also, there are potential medication side effects. So we know that tenofovir, whether it be TDF or TAF, has an impact on bone health and metabolism. So we need to be cognizant of that as we are coming up with HIV regimens for patients. Prevention and mitigation, again, smoking cessation, figuring out if they need vitamin D and calcium supplementation. Who do we screen? Postmenopausal women and men 50 to 69. That seems to be a consensus across both European groups as well as US-based groups in terms of when we should begin screening. Also should assess other risk factors, again, smoking. So in people who may have other risk factors, we may consider starting screening earlier, especially if they've had a fracture. There's a tool called the fracture risk assessment tool that has been used in persons living with HIV to determine what their risk of having a fracture is, because we want to know that, because we do have medications that we can prescribe to help with bone turnover so that we don't have thin bones that will break and then lead to adverse outcomes like hip fractures, hospital stays, and things like that. The FRAX score has correlated some with a 10-year risk fracture risk in people living with HIV, meaning that they've looked to see how well that score is able to predict fractures in persons living with HIV, and it does pretty well. So treatment, so bisphosphonates, so the alendronates of the world are okay to use in persons living with HIV. Vitamin D and calcium supplementation, everybody's pretty much vitamin D deficient. Evaluate for underlying causes. So again, low vitamin D, do they have phosphate wasting, which can happen sometimes with certain medications, and avoiding tenofovir, TAF, or TDF, or ritonavir boosted PIs, which we don't tend to use as much anymore in persons who have osteomalacia, which is thin bones, but not osteoporosis, which is brittle bones. Neuropathy, I alluded to this a little bit earlier. Again, virus effects on the nervous system. About 30 to 60% of persons in one study who were living with HIV were reported neuropathy. We also see neuropathy in other medical conditions such as diabetes. So if you look at someone who is 55 and older who may have diabetes and then has HIV, they may have neuropathy. The mean time to development in one study of neuropathy following an HIV diagnosis was almost 10 years. So again, viral proteins that impact the sensory nerve fibers, causing the pain and burning and numbness that people experience, which again affects quality of life. It can impair mobility significantly. And if we choose to prescribe medications, we have to be cognizant of the fact that some of those medicines may have adverse effects or have drug interactions with some of the other medicines our patients are taking. So we need to be aware of that. Not to say that we shouldn't prescribe therapy if it's appropriate, because we do that all the time, but we just need to make sure that as we're adding more medicines and potentially contributing to polypharmacy, that it's not leading to any risks for drug-drug interactions. Sexual changes. So again, needing to talk to our older patients about their sexual practices. So, and what are their experiences as they're kind of moving along that spectrum of getting older. So menopause in women, they may experience decreased libido, menstrual abnormalities, mood changes, lots of other symptoms. The decrease in estrogen can impact bone health, which is one reason why we see osteoporosis more commonly in postmenopausal women. There's usually no specific testing indicated to diagnose menopause, even though I have patients come in all the time who want me to check their hormone levels, but that's not how you diagnose menopause. You can consider hormone replacement therapy, but in limited for a limited time only, just because of the increased risk of certain malignancies, and also blood clots, in persons who are on hormone replacement therapy. Hypogonadism is defined or is experienced by patients who report decreased libido, erectile dysfunction, because of the decreased testosterone levels. They also have reduced bone mass, so they are again at risk for having some of those fractures that we talked about earlier that can impact quality of life, mobility, etc. Diagnose it with serum testosterone levels. Insurances require you to have two morning serum testosterone levels measured at least 1 week apart in order to approve it. And you can use testosterone replacement therapy. Malignancy. So age is a risk factor for malignancy, for multiple types of malignancy. So the older you are, the higher the rates of certain malignancies, such as prostate cancer. We usually see that in men as they get older. Persons living with HIV also have increased risk of developing cancer, as well as developing secondary malignancies too. Most cancer deaths among persons living with HIV are attributable to non-Hodgkin's lymphoma. Again, immune activation can lead to lots of issues with lymph nodes. Lung cancer, Kaposi sarcoma, which is not as common as it was many decades ago, but we still do see patients with Kaposi sarcoma. Liver cancer, anal cancer. The mortality rate is also higher in older persons living with HIV who are over the age of 60. Many of the malignancies are virally mediated, meaning that it's another viral infection that triggers that. So Kaposi's is one that's mediated by human herpes virus 8. Cervical cancer is HPV, hepatitis C and hepatitis B, non-Hodgkin's lymphoma, and anal cancer is also HPV related. So for vaccine preventable malignancies such as HPV mediated anal or cervical cancer, we should be vaccinating our patients when they're younger, so that as they get older, we don't have to worry so much about that. So some of these we can screen for. So cervical cancer screening, the guidelines for screening have changed a bit over time. We're still not starting screening until age 21 and women, or people assigned female at birth. We don't do HPV co-testing in those patients either. As they get older, over 30, we will do HPV co-testing, because HPV co-testing, along with looking at whether or not there are abnormal cells on the cervix, helps us to figure out what is the risk of them progressing to cervical cancer. So there's been more of a move towards using HPV co-testing as a guide for stratifying risk and determining follow-up. Lung cancer, a lot of our patients smoking cessation. So there are higher rates of lung cancer amongst persons living with HIV than in persons who are HIV negative. Again, probably multifactorial, including some of the things we talked about regarding immune activation, colorectal cancer and prostate cancer. Renal and liver disease. There is an increased rate of kidney disease in persons living with HIV. Some of it is virally mediated. For other folks, it can be mediated by some of the medications we use. Risk factors include being Black, African American, having a low CD4 count, high viral load, having a family history, and having some of the other comorbidities that contribute to chronic kidney disease in HIV negative persons. Fatty liver disease, or non-alcoholic fatty liver disease, is common in persons living with HIV as well. Some of the medications that we use that can contribute to higher lipid levels can be contributory. So those are things to keep in mind. there also higher prevalence of HBV and Hep C in persons living with HIV. So we should be screening for those and treating as appropriate. I couldn't find a lot of data on gender affirming care as folks get older. I think that's been more of an accepted thing in the last probably 10 years. So we do see here, I did find some data that show that if you look at the ages of trans women diagnosed with HIV, we do, the numbers do drop off as people get older, but as gender affirming care and acceptance of the spectrum of gender identity has become more common, I think that we will see those numbers increase as our patients with HIV who are in the LGBTQ community get older. We will see those numbers increase also. So considerations need to be given to potential drug-drug interactions, as well as interactions between gender-affirming hormone therapy and the psychosocial care of our patients, including our trans women, particular trans women of color. They're one group that continues to have higher rates of HIV infection for all of the reasons that you could possibly think of, including stigma, acceptance, psychosocial support, etc. Substance use disorders. Older adults, including persons living with HIV, may be more vulnerable to effects from substance abuse use disorder, because as we get older, we can't metabolize things as we used to when we were younger. So whatever substances that were being used may hang around more. Persons who are older who may have had longstanding substance abuse issues may not be used to some of the shenanigans that are going on with illicit drug use now. I just had a patient I saw yesterday who told me that she had stopped using cocaine, partly because she wound up overdosing unintentionally on fentanyl because her cocaine was mixed with fentanyl. Cocaine itself does have cardiovascular and cerebrovascular impacts, in addition to the HIV, in addition to some of the other comorbidities. Marijuana is a little bit controversial for some people to talk about the risk, but I always tell my patients, I don't care if it's weed, tobacco, whatever, smoke doesn't belong in your lungs. And so that's something to consider. People can get their THC in other forms that do not involve inhaling it. And I think there's still a lot of research that needs to be done on some of the other modalities in which people are using or getting THC, including research on how that impacts persons living with HIV. And alcohol, which is the most commonly abused substance because it's legal. And there's a lot of potential impacts from alcohol use, including on the liver, the cardiovascular system, the nervous system, brain, all of the things. Excessive alcohol use can also cause neuropathy. Mental health disorders are common in persons who are living with HIV, as they are in patients who have a number of chronic medical conditions. So one study showed that about 50% of all persons living with HIV have some sort of neurocognitive disorder. So again, immune inflammation and activation affecting the nerves in our body, including those of our central nervous system. HIV-associated dementia is 3 times higher in older persons living with HIV than in younger persons living with HIV. And there's also a cumulative effect, right? So HIV infection, whether or not you have cerebrovascular disease, such as high blood pressure, you've had a stroke, you have high cholesterol, and then the inflammation being caused by the HIV itself. And there is evidence that there is improvement after ART initiation, which means that just because you may have some neurocognitive issues at the outset doesn't mean that that's always going to be the case. I've over the years, I've had patients come in who were completely just cognitively not able to process much. And when patients often come into care, especially if they have higher viral loads and lower CD4 counts, it's very difficult to tease out if they have some other underlying cause for their cognitive dysfunction, or if it's just the HIV. And so the way that helps us to tease it out is to start antiretroviral therapy and see if things improve, which for many patients, it does. I've had patients who came in and couldn't remember their first few visits with me because they were so sick. And as they improved, their cognition improved. And then we already talked some about depression. So summary, improvements in antiretroviral therapy and access to medical care, including through the Ryan White program for persons living with HIV, have led to increased longevity. So if we remember that curve, especially in Virginia, we're going to continue to see increases at that other end of the curve. As a population of persons, older persons living with HIV continues to increase, there is a need for ongoing research and evaluation tools specific to those aging with HIV. So some of the tools we talked about haven't necessarily been validated and tested. So the MOCA for mental health screening, the cardiovascular risk tools that we use, Framingham, and the American Heart Association. We use them because we don't have a tool that's been validated specifically for persons living with HIV. And ideally, in a perfect universe, we would have a multidisciplinary approach for providing care to older persons living with HIV. Ryan White clinics are very good at doing that. And so that is one of the benefits of having patients in our Ryan White programs, is that we are able to provide a lot of those wraparound services that other clinics don't have the capacity to do. And the kind of multidisciplinary team approach helps to coming up with a plan that is specific to each individual patient and can help them as they age with HIV to continue to live their best life. Any questions?
All right, do we have any questions in the chat?
Good afternoon. I'm Raymond Beveridge. I'm with the City of Manassas, appointee to the Prince William Commission on Aging, which advises the Area Agency on Aging. And Doctor, thank you for this excellent presentation. There is, under the comorbidities, two things that have been cropping up, and they've noticed that in the jail transition program, the George Mason University Mason and Partners Clinic works with the regional jail as they transition back, is the number of persons with HIV that also have Hep C.
Yep.
And hepatitis C. So that's one of those new factors in there. And the one that is cropping up, unfortunately, is tuberculosis and HIV.
Yeah.
So if you on that one, could you address, because you're also in a big metro area, like I'm in Northern Virginia. And so I think the Richmond RVA also has that issue.
Where we've been seeing, so one of the recommendations is that persons with living with HIV, they should have a screening for latent tuberculosis. We don't do the PPDs anymore. Most places have gone to doing the quantiferons, which is a lot better. You don't have the inter-rater variability that you did in the past. Plus, you don't have to worry about somebody having to come back to get it read. We haven't seen too many cases, at least in the clinics that I have been in of latent tuberculosis amongst our HIV positive patients, where I've seen it mostly is in our immigrants um, from South and Central America. And then we also have been seeing quite a few Afghan refugees through a partnership with the Virginia Department of Health. So, but yeah, it's a challenge. And, you know, I'm glad you kind of brought up the fact that some of the things that we thought were, you know, what's old is new again. So, you know, we thought, you know, it's like, why are we talking about TB in jails in 2022, right?
Right.
And just the same reason we're talking about polio outbreaks in New York, because if we let our guard down, a lot of these pathogens kind of rear their ugly heads again. With respect to Hep C, there has been a lot of support and encouragement from HRSA to treat those who are co-infected, even within Ryan White programs. So at our program, we see both Hep C and HIV. The fact that many of the patients who were previously underinsured and who may not qualify for Medicaid, who now have insurance through the marketplace, that has really been super beneficial in terms of being able to access treatment for hepatitis C. Medicaid expansion has enabled us to do that as well. But yeah, so about 30% of our patients living with HIV are estimated in some studies to be co-infected. So not surprising. But, you know, depending on the capacity of the local regional jails to address all of the things that we expect them to address, there are gaps when people transition out. And you know, those are systems that we need to try to strengthen, especially for older persons who are coming out of incarceration, who may not have any, the world has changed since they were locked up and they're lost. You know, they don't know, it's just a completely different environment, especially depending on how long they've been locked up. And so that can be really challenging too.
Well, thank you for that. And I got a short question, but it probably has a long answer because there's not much hard data on that. But what are you seeing in terms of our friend long COVID and AIDS, particularly since what is it? PCP, pneumocystis, pneumonia is what originally was the diagnosis way back, 1982 for AIDS. And now is showing up in long COVID.
I haven't had, I don't know that there's a lot of hard data on long COVID and persons living with HIV. I think there was initially a huge concern that persons living with HIV might fare worse with COVID than those who were HIV negative. But I don't know that that bore out kind of across the board. Of course, if you have a CD4 count in the single digits, of any pathogen's going to make you sicker than if you have a CD4 count in the 600s. But I just don't know that we have enough data on long COVID period, let alone for persons living with HIV. So I think that's another future area of research as we kind of move forward from more of our acute phase with COVID into more of a chronic. We're living with COVID from now on.
Yeah, true. More research is needed. And as my favorite, having had paid for two grad students in my family, my wife and my son, that's what you have grad students for, to abuse.
Yeah.
So thank you very much, Doctor. And there's a question down in chat.
All right, thank you for that question. The next question in the chat: what would you say are the two most important needs to train our HIV clinicians in using assessment tools for integrating geriatric care for our clients?
Oh, that's a tough one because geriatric care is complex. Some of the papers that I was looking at were suggesting having geriatricians in the HIV clinic, people who are specifically trained to take care of aging populations, but I again, that's ideal. If we can have that multidisciplinary approach and have access to geriatricians. But I think that comprehensive geriatric assessment is a good place to start. Is use that's a good tool. Again, not 100% validated for outpatient use. But again, a lot of the tools that we're using for taking care of our patients haven't been specifically validated for persons living with HIV, let alone persons who are aging with HIV. So it's a good place to start. It gives you kind of a checklist of things to start looking at and questions to ask. It also, gives you in Ryan White clinics where you may have access to a nutritionist or to case management or to pharmacy, get some of those extra hands involved in looking at the patient's medications. Are there drug interactions? But the comprehensive geriatric assessment, I think, is a good place to begin to start assessing some of those needs that our patients may have as they're aging.
All right, the next question. Given the lack of geriatricians, which are mostly in large medical systems, my interest is how can we take steps to integrate care for older patients into HIV care?
And I think it's similar to, a lot of it's going to depend on how your clinics are set up. So some Ryan White clinics, and I'm just using Ryan White clinics as an example, are set up so that they have someone who will see the patient for HIV, and then they'll have someone else who will do primary care. I'm not a big fan of that. I think it makes sense if the provider is adequately trained and the staffing is available, that if the HIV provider can be the primary care provider, that helps a lot, especially as you start looking at managing other comorbidities like diabetes and hypertension and doing all the routine screenings. The less you kind of piece out the patient to different subspecialists or to different medical providers, I think the better it is for the patient, especially as people age and may have challenges getting to the medical clinic. If there's one main prescriber that helps to cut down on the potential for random medication showing up on a patient's med list and the patient doesn't know what it is or why they're taking it, and then you wind up with a drug interaction that you had no clue was coming. So I think how you structure getting your Ryan White providers to do the primary care is going to be based on how your clinic is set up. If it is, I would encourage the Ryan White provider to also be the primary care if that's possible, and to start using some of the tools that we talked about today for assessment. And again, it doesn't have to, not everything, you can't do everything in one visit. So that's one of the things to emphasize, is that it can start out with, okay, we're going to focus on these two big things today. What medicines are you taking? Try to work on polypharmacy and maybe cognitive assessment to make sure that they're able to understand the treatment plan. But you can, do this over several visits. It doesn't have to be all at once. I don't know if I answered that question, but it's challenging because it's asking people to maybe develop a skill set that they may not have had to develop in the past.
All right, our next question. Is depression more related to the HIV/AIDS diagnosis or primarily in the diagnosed state of the disease?
I don't know that that's, I think it's all of the above. We know that rates of depression are higher in persons with chronic illness, period. So and persons who, there have been studies looking at people who have had heart attacks. And so after they survive the immediate heart attack, there's increased rates of depression. So as HIV has transitioned into a chronic illness similar to diabetes and hypertension and things like that, I think you have that aspect of it being a chronic illness. That's not to minimize the impact that stigma still has on persons living with HIV. We don't talk about HIV as much anymore as we used to in the past. A lot of people, don't necessarily think about it anymore. There's still a lot, and because we don't talk about it as much as we used to maybe 10, 15, 20 years ago, there's still a lot of misconception and a lot of just bizarre ideas about who gets infected and how they get infected, and that has an impact on people's mental health as well. And then if you're looking at other, communities that have been further marginalized, including people who are homeless, people of color, trans women, particularly trans women of color, all of those things add into the depression. And one of the studies did show that there are higher rates of PTSD among persons living with HIV. So that could be from a number of different factors. So I don't know if that answered the question, but I think it's all of the things. Living with a chronic illness, any stigma associated with HIV, if you're a person of color, if you're a trans woman, if you are marginally housed, if you're unemployed, all of those things play into it. And COVID made a lot of things worse, particularly for older folks. So a lot of older folks who sheltered at home, I had patients that the only time they ever came out was to go to the doctor. So they didn't interact with family, friends, their church, they just weren't leaving the house. So it made them even more isolated than they had been pre-COVID. So it's all of the things, not just one singular factor.
All right, do we have any more questions out there? Well, at this time, we'd like to thank you for joining us in our breakout session on aging and comorbidity with Dr. Veronica Ayala-Sims. And we appreciate your time. We'll look forward to everyone joining us in the next session. Have a nice day.
Thank you for the invite.